So it's great to have you all back again. Welcome. And I'm going to go through a compressed slide deck, which will hopefully give you more room to ask questions. I bring greetings from Doctors Parahone and Ross, who are probably two of the hardest working state employees there are right now, as we are in a week with record case numbers. So Brianna, if we could go to the next slide, and there's a lot of information on here, and I'm going to start by focusing our attention on the graph on the right. The dotted black line, as probably all of you know, is the average case count, averaged over 7 days from the very beginning of the pandemic till today. There's a little gray area, which means we don't have complete data yet. There is a downturn, which we suspect is real or will be real in the coming week. But just noteworthy is that dotted black line peaks at a point that's 2.5 times our previous peak that we had in last November. And so I also like to say this dotted line is how careful people should be in the midst of a pandemic. And, if the line is low, then we can relax a little bit. But we haven't spent a lot of time below that red line, which is the red line is high risk, believe it or not. But we're way above high risk today. And so extra caution. We've given you some.
Dr. Grace, if I may, that dotted black line, thank you so much for sharing that. And you saying that tells us how cautious we should be. But I think it's important to remember we always need to be cautious. That helps us with that change in behavior. So when we see that spike and we see that it goes up, that means that might be the time for you to support businesses, but do some pickup or have your food ordered and brought to your home instead of always going out, which provides that platform for you to be exposed much more. So it's helpful in telling you, all right, now is the time where I need to alter my behavior a bit.
Yeah, that's a really good point, Marissa. And also, we are just seeing an awful lot of indoor transmission right now. And so just all be aware, indoors without a mask, outside your home, very high risk. Also, it's worth mentioning that I think every single person who's tuned in today would be able to answer that right now, we each know more people who have COVID than we have since the beginning of the pandemic. That's a reflection of these case counts and also the infectivity of the Omicron variant. And so we are looking forward. I think our modeling team is saying we're getting really, really close to the peak. Could be in the next 3 to 5 days. We're starting to project a downward trend next week. So that's really good news. Over 20% of New Mexicans now have had COVID. There is another bright spot, and I wanted to show you that you can see that case counts just for this month, it should say January 10th, January 17th, and January 24th at the top there. You can see maybe a little stabilization between last week and this week in the case counts. Hospitalizations still going up. I wish we had only 424 hospitalizations. Today, I think we're sitting in the mid 600s. But one really interesting fact that's cued in by the asterisk is, we've been following the number of people who are on breathing machines, intubated on a breathing machine since the beginning of the pandemic. And when you take that number and divide it by the number of hospitalizations, we're at 9.2%, which is the lowest it's been during the pandemic. That doesn't mean the virus isn't dangerous. It doesn't mean that there isn't a significant mortality rate, but it does mean a break, particularly for our ICU doctors and nurses, respiratory therapists, and others. That's really actually quite welcome. Unfortunately, all of the pressure has shifted now from the ICUs to the emergency rooms. And so we're working actually bringing in additional staff on the state sponsors and sending them actually to emergency rooms. I got a text this morning that we were deactivating some folks in an ICU setting in one hospital and moving them to an emergency room setting. So that's the tenor of what's happening right now. We are seeing, because of that lag, an increase in deaths. One other interesting thing that is interesting to me is that usually we count on a 2-week lag between when cases go up and hospitalizations go up. Same on the way back down. When cases start going down, hospitals have to wait 2 weeks for their emissions to go down. That's shrunk to 1 week. And so that means that if it's good news for all of us about the peak here in the next 3 to 5 days, it's also going to be good news for the hospital in the next 10 to 12 days. So a lot of positive news, but again, caution, be careful, be watchful. COVID is everywhere right now. Great progress on vaccines. Over 90% of New Mexicans have received one shot, but the key here is the booster. The key to fighting COVID today is the booster. And so that's why we talk now about being up to date with your vaccines. And I think you all know what that is, but if it's been less than 5 months since you had the Pfizer Moderna series, then you're up to date. Good for you. If it's been more than 5 months and you don't have a booster, you're not up to date. And of course, if you had a booster in the last 5 months, you're up to date. Someone will ask, well, are we going to need another booster? And the answer is we don't know, but we'll have more data of our own and from the CDC, probably in early March, I think, when we're 5 months out from when we started giving boosters to everyone. Okay, a lot of information, but I wanted to hit the high points there. Next slide, please. Here's some new data, really hot off the press. We do have our age-adjusted death rates for the state of New Mexico for 2020. I know that's a long time ago, but it is, there's a lot of processing and verification that goes into this data. It's from one of our data systems. The link is at the bottom. But COVID now officially is the third leading cause of death, was in 2020. And again, a reminder that these are the leading cause of death as listed by their physician or other care provider on the death certificate. So it's not some determination made by DOH, although sometimes the Office of the Medical Examiner over at the university will make those determinations when it's unknown by the treating physician. And so it again underscores the fact that this is dangerous. Also, it's worth pointing out here that heart disease and cancer are not contagious. You know, coronavirus is, and so it puts it in a different category. It's been a long time since we've seen a shuffling in the order of this, and particularly with such a strong number of cases at number 3. So it's official in New Mexico. We've seen national trends in this direction as well. So still a serious disease. We talked about plane crashes, and thanks, by the way, to those who corrected me. I said 1.16%. It should have been 1.6%. So thank you, Chris McKee, on that one. I did misspeak, but still very serious. Don't take your chances. Don't think that you can just get COVID and be fine. Next
Dr.
slide.
Grace,
Yes.
that's exactly what I was just going to highlight for you as well, is that you mentioned that heart disease and cancer are the leading causes of death, but they are not, they can't be transferred. There isn't contagion surrounding it. But it's also just important to note that with the coronavirus disease, it can be much more preventable. There are things you can do for heart disease and cancer to try to lessen your risk, but then there's hereditary issues that can come into play that you don't have any control over. As far as the coronavirus, you do have some control over getting that disease, and that's why it's so important to use all the measures that we have to protect yourself.
Yeah, and that's exactly right. I mean, I'm doing things and exercising and watching my diet and even taking a few meds to prevent heart disease, because I'm in that age group now where that's the right thing to do. But in terms of behaviors, there's a lot I can do to protect myself, my family, my community from COVID. Next slide, please. So let me walk through this, getting a lot of questions from you all and also from the public about, can someone please explain to me what the CDC says we're supposed to do now when it comes to if I have symptoms? And so the new motto is don't wait, isolate. So some people will kind of go, you know, I'm not really feeling well, but I think it's just allergies. And those of you who suffer from juniper, like I do, you know, are waking up every morning probably now with itchy eyes, which is not a characteristic symptom of coronavirus. But if you have symptoms that are compatible with COVID, and I think we all know what those are, with respiratory or GI tract or headache or particularly loss of taste or smell, please isolate right then. We're going to talk a little bit more about how you could just do a test that day in your home if you wanted to, and we'll focus on that today, but isolate. Don't say, well, I'm going to give it a couple of days, see how I'm doing, and I'm going to go to work today, and then I'm going to go out to dinner tonight, and then I'm going to go to the grocery store tomorrow. Don't do that. Don't wait. Isolate. And we will, if you do have symptoms, we are working, as you know, to divert a lot of the testing for asymptomatic people to home testing, so there's more room and more access for testing. So if you do now, if you test positive, you want to stay home for 5 days. And this is for people who are not up to date with vaccines. So if you're not up to date on your vaccines, you need to stay home for 5 days. And then when you come back into society, regular life, going to the grocery store and the like, you need to wear a mask for 5 more days. That's the current CDC guidance for someone with a positive test who is not up to date on vaccines. And I think we're going to drop in now. Well, what about people who are up to date with their vaccines? Like, what would I do? What would Marissa do? What would the other staff on this putting together this press conference who have their boosters? And it's different. We don't have to stay home, even if we're and this is different. And I'm confusing things a little bit, so let me clear this up.
It is a little confusing.
Yeah, I'm even getting confused. So the graphic on the right is what you do if you're not up to date and you've been a contact of someone with COVID. And so you may or may not have a test there, because that little day 0 can be a little confusing. So this is just, I had a contact with someone who I know is COVID positive, maybe a family member, coworker. You're not fully vaccinated, stay home for 5 days, come back with a mask. If you are fully vaccinated and you've had contact with a COVID positive individual, then you don't have to isolate, or you don't have to quarantine. You can just come back to work with a mask on. Now, people are having trouble believing this. Like, seriously, isn't that dangerous? But if you have a tight fitting, effective mask, you can monitor yourself for symptoms. You might be asymptomatic, but as long as you have an effective mask on, you're not going to infect someone else. And so again, let me just one more time. This is about people who come in contact with folks. We try to combine a lot of information into one slide, and I'm wondering if next time we should do 2 slides. But if you're in contact with someone not fully vaccinated, 5 days at home, 5 days out with a mask. If you're fully up to date with your vaccinations, then it's 10 days with a mask. So it's confusing. I'll have it down by next time and be clear on that. And then there's a whole nother set of guidelines. So Brianna, when we send out the slide deck to people, let's take out that day 0, because that refers to people who are COVID positive. And this is a contact slide. Next slide, please. Masks matter. What are we going to do about masks? I'm getting a lot of questions now. What kind of masks are you wearing? I'm getting that one now. In patient care, I wear a N95 from the moment I get there till the moment I get to my car. When I'm not in patient care, I have a nice KN95 that's a certified one that I throw on. This is like I get here at 6:45 in the morning. I throw it on and run up to my office here at DOH, or the other one at HSD if I run out for a second. But if I'm going to be in a meeting or with people face to face, which doesn't happen that much right now, I would put my N95 on because I'm indoors and I want the most effective mask. The cloth mask we started with, they protect you a little bit. They protect you from transmitting a little bit. But as you move up the line, they become more and more reliable. And so we're working this week to come up with a plan to ensure that we have solid recommendations for folks in New Mexico about what they should do with masks, what kind of mask you should wear. But I'd really encourage everyone, as you're able, to move away from cloth masks, move up this or move from the left to the right. And the most important thing is a mask fits tightly. You know, we've all had the experience of wearing a mask that fogs up our glasses really badly. And, you know, that's not a tight fitting mask, unfortunately. It means that air is leaking up and fogging your glasses. So tight fitting, when you can stand to have on all day, I can tell you as a healthcare worker, it's a lot of work working with an N95 mask on all day at work. It's a challenge. They're harder to put on and take off. They're really tight. You have lines on your face till you wake up the next morning, et cetera, et cetera. So we want the stronger the mask, the better you're protected, but more importantly, the better other people are protected from you as well.
Dr. Scrace, I'm hearing that some hospitals are requiring employees to wear the N95 masks and others are saying the KN95 mask. But how do you know that they're actually the real deal?
Yeah, there's some good articles on the internet where you can decide from yourself and sort it out. I know one healthcare delivery system that doesn't allow KN95s, and it's not because of effectiveness. It's about source control. And so rather than having a station to look up every KN95 that comes in on a nurse or doctor's face, they're saying, we have enough N95s now for everyone. We'd like you to wear them. The state is also working to procure both N95 and KN95 masks. We will assure that those KN95s, which frankly do work better for some people, in terms of comfort, fit, ability to wear all day, seal, tight seal, we'll make sure that the KN95s are reliable, aren't those knockoffs, really are effective. And and the ones that President Biden and the current administration, federal administration, will be sending out, same deal. And so keep your eyes peeled, if you will, for that offer from the feds. And also the work we're doing here in New Mexico to supply those masks. And if you get them from those two sources, they will be high quality. All right, next slide, please. Here's a graphic that I put together that I think helps explain, and I tried to do this last week just with words, but for me, pictures work better than words. And so the green or turquoise, we tried to make it turquoise on this map with our flag is New Mexico and the percent of the effort that's being put forth by the state, and then also the percent of effort by the federal government. And so you can see we're in filling that gap mode until the federal government gets up to speed. I do want to pause and, like everyone, while you're listening to this press conference, if you have not gone to covidtest.gov to order a mask, do it while I'm talking. It's that easy. They just need your name, address. They need a delivery address, not a post office box. And you need to be the first person in your family signing up. We had our whole DOH team sign up the first day. It's fascinating to see who's getting their tests when. I mean, our lab director, Mike Edwards, got his yesterday. Christine Ross, both of those folks are physicians, got hers yesterday. I haven't gotten mine yet, but someone loaned me their two that they got. So you'll get 2 boxes of home tests, and you each one contains 2 tests. So that makes 4 tests. And so one of the best ways to help New Mexico meet the needs of New Mexicans is to take advantage of this blue area and have a rapid response. I mean, this is a way actually, I don't know the exact number of households, but we could have 4 million home tests in the state in the next 4 weeks if we got everyone to sign up. That would help us a great deal. So sign up now. Click on the link or go to the website. It's easy to type in, not like most of the links we give you, and you can get those right away. I have noticed from the post office that mine will be here Saturday by 10 p.m. I didn't know the post office delivered at 10 o'clock at night, but we'll see how that works out. And I'm excited about that because this is going to be a big help. In addition, the state, to fill this gap, has already ordered 1 million masks. We've already distributed those to communities throughout the state. We can give you the zip codes exactly that they went to. They are focused on the high social vulnerability index areas. I think you also know that those areas, folks who live in those areas are twice as likely to get COVID infections, 2.5 times as likely to be hospitalized. And if they're hospitalized, 2.5 times as likely to die. So that's a big burden. We are the #1 state in the sense of having the highest social vulnerability index across the state. So right now we're filling the gap, kind of where the area where the New Mexico flag is. But the way the federal government currently is distributing everything, tests, treatments, probably masks, is more on a per capita or per rata basis by population. If our social vulnerability is twice as high as the average per state in the country, we're going to need to provide just as much resource to the federal government. So now it's being delivered locally. Watch the news in your area. We'll have more information and sort of a compendium for you next week from the emergency managers in each county. And I know some of those are already available in some counties. And then that area on the right, Brianna, if you can point to it, I think I'm envisioning a steady state where New Mexico provides about half our need and the feds provide about half our need. So we're getting ready for that. And we're also actually working with Medicaid to actually combine our efforts. So at some point down the line, probably in April or so, we'll be able to have HSD customers, which would be SNAP, Medicaid, and our other programs. And today, by the way, there are 1,051,755 folks who are our customers, exactly half of our population. We're going to try to set up a direct order route for them as well for tests and masks. It's early in development. There's obviously a lot of details to work out, but something I'm excited about and something that hopefully will make it easier for those people who have internet access to just order them from home. And for those who don't, of course, we'll have a call center to do that. We have masks on order as well, and so do the feds. And so watch for those as well. But those second million tests are on the way, I think, here this week and early next week. And we have another 500,000. We're working on this as we go to get that emergency fill the gap supply out there. And then after that, we will expand. But please, again, one last time, go get your free tests online. Federal government's doing a great job delivering those. I would love to see however many we can get, if that's 4 million or whatever it is, into our state in the next 3 to 4 weeks. That will really help. And we'll talk a little bit more about that in a minute. Next slide. Remember that the more layers you add, the more block places there are to block the virus from getting to you. So in these super high case count times, like record high case count times, I'm not going to large gatherings myself. I'm trying to keep my distance, reconfiguring work so we meet online virtually all the time. I'm keeping my hands super clean and washing them frequently during the day. And we have that, hand sanitizer virtually everywhere. I wear my mask. I already told you what I'm doing with that. And then getting tested. When we have these kits at home, if you and you have symptoms, you'll be able to do that first test immediately. And finally, of course, the most effective barrier, which you'll see doesn't have too many holes in it, is that vaccine plus booster. And that's what we're really seeing in our own New Mexico data, is providing the most protection. And I think we're about to wrap it up. So next slide, please. So the takeaway messages for today: don't wait, isolate. If you have symptoms, don't just assume it's allergies. Remember that girls basketball team in Albuquerque that had really bad allergies for a week, and then they found out they all had COVID? Don't let that be you. Isolate yourself right away. Get your booster vaccine. It's our most effective defense right now. I'd love to see that up to 100% of people with their primary series being boosted. Be prepared. We don't want people stockpiling tests, but have these tests at home. Don't wait till you're having symptoms to go online to order your test, because it's not going to come in time to really help. So have some of these at home as masks become available from state and federal government, order those right away as well. And then lastly, just remember, we're having this virus, this Omicron variant, 10 times as infectious as as we saw at the beginning of the pandemic. So please be 10 times as careful. We think we're going to get over the hump here, but we need your help to get over that hump. And if we are more careful, we'll see ourselves going down the other side of this case curve soon. And I think with that, I'm done. And
Yes.
Marissa, I'll turn it back to you.
All right. Thank you so much, Dr. Scrace. We're going to start with Jared Ebenreck from KUNM News. Jared, go ahead and ask your question.
I'm hoping you can hear me.
We can. Go ahead.
Thank you so much for confirming that. My name's Jared Ebenreck, KUNM News. I had sent in a question about contact tracing, but there is a separate question that the last slide sort of stimulates. I'm wondering if in both of your words you might help New Mexicans understand, given the last few years, what does it mean to you now to learn to live with COVID-19?
Yeah, Jared, that's a great question. I've been talking about it and the concept since I think August of last year. And so, and I think I'm starting to understand what it means now as the situation has evolved and we have so many good tools for handling the pandemic. So I think the first principle of learning to live with COVID is a transition from the government telling people what to do to individuals taking personal responsibility for their own health, the health of their family, and the health of their community. And so that's critical. And I think we've all driven around, and I occasionally make a furtive dash into my local big box store to get some materials for my latest home improvement project. And we know that there's varying levels of that sense of personal responsibility with respect to masks and the like. So that's number one. Two, I think, is bringing all the tools to manage COVID home. And so I think that includes having that supply of masks we talked about, so they're available, but having testing at home. So when you get symptoms, you can test immediately. And we're waiting for additional guidance about whether there's a second test in there and exactly which day it is. So you can isolate immediately, know you have COVID. I think third is treatments are coming home too. I mean, we're with the advent of Paxlovid, which is that oral agent, which is actually the most effective treatment we have for preventing hospitalization and death, even more effective by a few percentage points than sotrovimab, which is the only remaining monoclonal antibody we can use right now in Omicron. I think that bringing those tools home and having them at home and being able to take pills at home, I mean, it's starting to sound more like influenza, right, than COVID. And I think just to try to answer your other question that you didn't get to ask, I think I talked about this last week too. What about contact tracing? I don't see having a giant phone bank of people calling people up to tell them that they have COVID as being a very significant part of our future. I think for the PCR testing for symptomatic people, that'll be even more automated. So we all get our result immediately with a link to go and read about guidance about what to do. I think it'll become more educational about that. And I think we talked last week too about NM Connect and other tools. In my idea of learning to live through COVID would be, I get a notification from NM Connect that says, oh, you've been exposed to someone who's positive, and I go home and I take out one of my rapid tests that I got from the federal government or from the state, and I, take the test and see where I was at and follow the instructions. So I think it's I think the individual responsibility, bringing those tools home, including treatments, are the two main factors, and then use of technology, the third, to replace this gargantuan human effort. I think other things, just to let you know, and don't freak out, but I don't think we're going to be really operating our response to the pandemic based on case counts. 3 or 4 or 5 months from now, I think we'll be way more focused on hospitalizations and deaths. I think our variant detection system will become even more robust. We have a great one here. And I also think because we have such good data, you're going to see from time to time, New Mexico, like we were this week, well, actually, like we were 3 weeks ago, we stopped the use of ineffective monoclonal antibodies here in New Mexico. And then the other day, 2 weeks later, the FDA stopped. So we're still going to be at the forefront, monitoring things closely, but I think delivering to people in their homes the tools that they can individually use to manage the disease. Well, that's what I'm thinking now, but Jared, come back like in a month because I'll have other ideas then too as things continue to evolve.
Right. As Dr. Grace has said before, COVID's not going away. It will be a part of our lives. And so learning to live with it and watching some of those trends that show we need to be more careful right now. And so and having some tests on hand, like he said. So it's kind of that preparedness and going on from there, but knowing that it's not going away. So the cautionary measures that we take are going to remain, and you have control over that. The next question, if Rick Ruggles from the Santa Fe New Mexican is on, then he has the next question he wrote in. After that, I see that there are some hands and I will call on people. Rick?
Hello, can you hear me?
Yes.
Thanks for doing this. Appreciate it. I wanted to ask, is there still a shortage or a worry about shortage of sotrovimab? Is there a shortage of Paxlovid? Does the testing shortage affect Paxlovid's effectiveness because there's the quick turnaround? And sorry, with remdesivir, does pre-authorization mess that up?
Well, great question, and I have all the answers. But first, before we go any further, I'm not aware that there's prior auth for remdesivir. There are some certification issues in nursing facilities to getting them geared up to deliver it there. But remember, remdesivir is a treatment that New Mexico sort of been a leader very early on, like in 2020, I think it was May. Almost everybody who came into the hospital with COVID got treated. And that was actually what it was for, is people in the hospital. Now, to your point, because of the shortage of remdesivir and Paxlovid, which yes, we do have right now, I would like to see everybody have access to treatment. We don't have that today. I was actually talking with the governor yesterday and she said, well, if, what can I do to help you? I said, go get me more Paxlovid and sotrovimab. And so we were, what happened in early January was we learned, as I just mentioned, that Bamedi and Regeneron were no longer effective for Omicron. That was 75% of our treatment per week. And so that just disappeared. So we're waiting for the supply chain to catch up. We've tweaked the criteria. So it's very easy to get molnupiravir, which is not quite as effective, but does significantly reduce hospitalization and death. We're making that really easy to get. You just have one risk and you can get that. And we have a good supply of that. We've got enough, but we'd like to have a great supply of the most effective drugs. And then, but if you know of an insurance company that's requiring prior auth, could you just put that in the chat? Because we will definitely follow up on that. We don't want any barriers to people getting treatment. And lastly, you talked about the testing shortage. I think once we get those tests distributed, once all of you, you should by now, you should have finished, submitting your request for your home tests, right? Once we have those in our homes, I think that delay is going to go away. And while sometimes a PCR might be indicated in follow-up, if one of these is negative, it's never indicated if the test is positive. If one of these tests is positive, you have COVID, proceed accordingly. You don't need additional testing. And then the last thing is, and I sort of mentioned this at first, we do have a plan over the next 4 to 6 weeks to redirect symptomatic people to PCR testing resources for the reason you mentioned so they can get a quick turnaround time and get their results. And then people who don't have symptoms using home testing. And then just lastly, to size this up, because I know when it happens to you and you can't get a hold of a test, it's 100% of you that can't get the test. But our average turnaround time for a PCR at the beginning of January was 1.3 days. It's now 1.6 days this past week. So it's about 8 hours longer, bit of a delay, but Paxlovid with that 5-day window, we still have room in there if people get signed up for testing immediately when they get symptoms. Thank you.
Thank you, Dr. Scrace. Next, we have Brittany Costello from KOB. Go ahead, Brittany.
Hey, Brittany, you might be on mute on your end. It looks like you are.
Yeah.
Hi, can you guys hear me?
Yes,
Yes.
we can.
Okay, sorry about that. I'm on 2 computers. So my question is about the lab turnaround time. Obviously, we've heard from some school officials, I think we talked about this a little bit last time too, that it's just taking a lot longer to get those PCR results to some of the people, I guess, who need to return to work. So I'm just wondering, are there some labs, more impacted than others? Are you guys aware of some of those problems? And what are some of those solutions?
Yeah, great question. Of course, with anything, there's variation, and that's true in New Mexico with lab turnaround times. The fastest lab turnaround times are Tricor Lab and the state lab division, our state lab. They're on I-20. Interestingly, Tricor and the state lab are right across from each other, just south of the Big I on I-25. They're the fastest, generally a day, a day and 3 hours at the most. Of course, if we send things out of state, there's that transportation delay. And so that's something we're keeping an eye on. We do give immediate feedback to labs when they get outside of our boundaries. And so that's an ongoing set of discussions. And then lastly, I think the episode related to the schools, in large part was actually related to something that every business in New Mexico is experiencing, which is having a whole bunch of people out with COVID. And so it wasn't so much the lab turnaround time as the personnel to come in and test. So we're very busy this week, and I think finalizing an additional contract. So we have a couple contractors working on this and able to help each other out. But basically, we're still pretty happy with lab turnaround. And while 1.3 to 1.6 might seem like a really long time, when we first started this, we were 4 days, 5 days on average. And the governor herself worked incredibly hard to push this down and down and down. So we want it to be as low as we can. I think the other thing to remember about lab turnaround time is hopefully you've now completed applying for these tests. The lab turnaround time for this is 15 minutes. All right, which is about as long as it takes me to get in my car, get out of my house, into my car and out of my neighborhood to get on I-25 to drive to get a PCR test. And so speaking of learning to live with COVID, I really think this is the long-term solution to test turnaround times. So we're working on it and we're getting an additional contractor. And remember though, that the median time really is 1.6 days, which is, what was that? 38 hours.
Thank you. Brittany, if you wouldn't mind, would you lower your hand just so we don't get you confused? Thank you so much. Next, we have Chris McKee from KRQE News. Go ahead, Chris, you're unmuted. Wait, not quite. Yes, you are.
Okay, great. Thank you very much. Another question along the lines of the learning to live with COVID thing, and this in respects to schools. I wanted to bring back up the thing that you mentioned in Jared's question, the idea of, maybe in the coming weeks and months that the state starts making those decisions based on hospitalizations instead of that overall case number. Notably, I know some school districts out there in New Mexico, though, are still really looking at the case number amongst their student body to determine even things like, should we do enhanced COVID protocols or should we do virtual learning for 2 weeks. And so along those lines, this may be a bit more of a speculative question, maybe something to address with Secretary Steinhaus as well, but I wanted to see if we could maybe get your thoughts as well about the idea of, should schools be maybe shifting a little bit more from the caseload amongst the student body thing to just the idea of what is the virus doing out there in the community, and hospitalizations maybe being a factor of that, or any thoughts on that?
Yeah, it's a really good question, Chris, and thanks again for correcting my math last week. I know all reporters aspire to correct my math, so you and Julia now are in the Hall of Fame. But it's a complicated question because, when I was talking about not focusing so much on case counts, like that's really at the state level, but in smaller and smaller environments, it becomes more relevant. So for example, if 2 out of the 3 people in our family had COVID, we would not be having family dinners. If 1 out of the 3 did, I or whoever it was would be eating in their room. So it's very relevant. I think the problem schools have faced the most is more having too many staff out to actually cover classes, which is part of the governor's effort to bring state employees in to help out wherever we can to keep the schools open. So, and then I think, as you know, hospitalizations are far less prevalent in kids than they are in adults. I think though, learning to live with COVID in schools, in my view, is getting as many kids vaccinated as we possibly can. I mean, that's you wouldn't have to do the test to stay if you were vaccinated or at some point vaccinated and boosted, for example. And so I think in schools, it's vaccination. I doubt that we'll have enough FDA approval for enough age groups to have that be a state sort of mandated thing for the next school year. I don't know, but I think that's less likely. And but so I think when you're in charge of a whole state, you have to kind of pick those things that are at crisis levels for the state. Like, frankly, hospitals have been now for 5 months. And when you're in an environment, then you have to look at all the data and things like how many teachers are out today. It becomes sort of the driving principle. And like, even if nobody from your school is in the hospital, if you don't have enough people to teach classes. And I said this last week, I've said it all week, every group I talk to, I say this, my departments, I say it, you need to have a contingency plan for what you're going to do if 30% of people are out one day, next week, because that's what we've seen across the country. So I think it's probably both, Chris. I think the bigger a population you get, the more relevant those critical resources are, but the smaller the community you have, then you have to deal with things like having enough teachers or things like that. So thanks.
Dr. Grace, I spoke with Dr. Ross about that same question, and she was explaining to me that that's why that trending is really important, and that black line that you were showing earlier, because teachers, they may not have a really good representation of what's happening in the positive cases, but what does happen is that Omicron is very contagious, and to assume that it's everywhere, it is everywhere. So you can alter your behavior during that time. Perhaps that's when teachers look at that trend and say, okay, we may need to make some adjustments based on that. In terms of hospitalizations, all right, that the hospitalizations tell us that when they're up, this is more severe. So when we look at that versus the case counts, it allows you to alter that behavior. Now, the next question is from Julia Goldberg from the Santa Fe New Mexican. You're unmuted. Go ahead, Julia.
Thank you. And it's the Santa Fe Reporter.
Oh, excuse me.
Hi, Dr. Space. May I ask you 2 quick questions since we're mixing things up? My first question is, it looks to me as though the percentage of breakthrough cases increases by about 4% each week. So we're at 53.8 this week. We'll probably be at about half the cases are breakthroughs as of next week. The booster increase was 4.3% over the previous week. And so I guess I'm just wondering if you imagine there's a kind of optimum percentage of booster uptake in a given week that maybe works against that slippage on the breakthrough case numbers. Does that make sense?
Yeah, it totally makes sense. And it's a great question. What I would be doing, Julia, is looking at the booster rate 5 months ago and comparing it to the breakthrough rate today, because, each day people roll off. I think there is an optimal rate of boosting we'd like to see in the state. And I'm not being facetious. It would be that everyone who's completed their primary series gets a booster this coming week. That would be the best. It can give us the most. But you're right. And we're working on the modeling team about trying to have a better way of assessing immunity to the state. Because, in other words, people who had their primary series, let's say for the mRNA vaccines with 2 doses in the past 5 months, they're immune competent, right? People who had a booster because of the time frame, they're immune competent as well. And then there's people who just had COVID, been infected, so they're immune competent. The trouble would be we could track that, but then when a new variant comes, we'd have to press the reset button, depending on the effectiveness of the vaccine and the booster against the new variant. So I kind of think about it more like we need to be getting more people boosted now than, like you say, I think the breakthrough cases we're seeing. But I think a good part, and I don't know if, I don't want to belabor these points, but we are proud of our ability, and I'm really proud of my team to analyze the data. Remember, we called the boosters for everything question a couple weeks earlier than other entities back in October, because we were seeing that breakthrough cases for the primary series go up by about the percent you described every week. So we think that the reason we're about to hit the plateau and turn back down is Omicron has found most of the people who don't have immunity, and it's running out of places to go. It lasted longer and went higher because it's so infectious, but at least the modeling suggests we're going to see that turn. So that's a good question. You always connect dots that I haven't thought to connect, and I like doing that too.
Next question is from Algernon Damassa from the Las Cruces Sun.
Pick those things.
Go ahead, Algernon.
Thank you, and hello, Dr. Grace. When I brought this up previously, I think it was maybe a little bit early, I had asked about long-term symptoms after a bout with COVID-19, and there are definitional problems and a lot that we don't know, but National Institutes of Health and other bodies are starting to do some research. So I thought I'd revisit to see what New Mexico is seeing as far as people unable to return to work or requiring other kinds of ongoing services because they're still experiencing neurological or other symptoms following their infection. Thanks.
Right. It's a great question. You're not going to like my non-answers about that in advance. And I think there's absolutely no question that post-COVID sequelae, which I think might be the new intermediate or temporary name, post-COVID sequelae, that I think it lasts more than 30 days, is a real thing. It affects 10 to 20% of people with COVID. And in order to figure out the answer to your question, we would need to start monitoring that either through self-reporting, which isn't reliable, provider reporting, which, that's hard. It's an extra step. But for providers to report, we still need a definition, or what are we talking about? I'm in our agencies that I'm affiliated with, maybe we're in the ballpark of 5,000 employees. We're not seeing much in the way of interruption of work due to prolonged absences. And so, but I don't think that's a very good sample, and there's no science to it. I'm just trying to rely on my own experience. But I think, that 1.1 billion that NIH got, really expecting to see some results from that soon, at least definitional results and ways that we can start tracking that. But absolutely no question it's there. 10 to 20% of people experience some symptoms longer than a month. I've had a few of my patients with that, and, but they seem to sort of gradually resolve. And my patients who are older, mainly fatigue and kind of a little bit of mental fuzziness, you referred to neurologic. symptoms. So I think we're just gonna have to wait and see. And if you could just pencil in on your calendar to ask me again in 2 months, hopefully I'll have something a little bit better to say and more satisfying.
Thank you, Dr. Scrace. Next, we have Stephanie Munoz. Go ahead, Stephanie, you're unmuted.
Hi, Dr. Scrace. I had one question. We're talking a lot about the mask, and I really enjoyed seeing the levels of protection. So thank you for that nice graphic. I wanted to know if, as far as DOH, if you guys had any idea when we can expect the mask from the feds. I've seen other states have started to get those at local pharmacies, community centers. Do we have any idea when those will reach our state?
I don't know that. And it's interesting because I also didn't know that other states were starting to get federally sponsored masks through pharmacies. I did know that that was their initial plan, was to make them available through pharmacies. We also have ordered 1 million masks, 500,000 KNs and 500,000 N95s. And I think we're looking at a 2 to 4 week delivery, but we'll know a little bit more. But no, I don't know, but I certainly will have our folks check. And I actually, right after this, I meet with our the governor's employee in Washington, and I'll have her check on that as well. Great question.
Dr. Scrace, Julia Goldberg has another question for you.
I know, she said she had two.
Thank you. I wanted to just check in about pediatric hospitalizations. Between the first week of January and now, they've risen 360%. And I know they're small numbers, so that sounds bigger than they are, but that it's a national trend that they're rising. We got 23 in the last week. There were 5 the first week of January. They're kind of exploding in other cities. And I wonder if you had anything you could share about that. Is that just a reflection of we've got higher numbers in general, or is there something happening in terms of children's vulnerability to Omicron, et cetera?
There was some brief reports at the beginning of the year about kids under 1 being more susceptible to COVID and perhaps more serious COVID. I haven't seen additional data where that pans out. You're right, the case counts are 250% higher than they were, even with the highest peak, maybe 300% higher than what we saw with Delta before that. And so you would expect everything to rise in proportion to that. I opened up the pediatric report and just maybe so everyone is on the same page as you. This is the COVID pediatric hospitalization report. Hopefully you can see this. I can make it a little bigger, I think. And, the different age groups, and this is like the number of cases per 100,000. So this line here would be 1/10 of 1%. And so, of course, everything is shooting up. 18 and over is buried in here as well, but you can see all the age groups, 12 to 17, 5 to 11, all on a vertical climb. But that looks very, very much to me like the case counts. And you can see here that, it's 2 to 3 times what it was at Delta. And that's what we're seeing in total cases as well. So at least at this point in time with the data we have, we're not seeing anything that makes us think that kids are more susceptible. It's so infectious, and kids are together in school. They're also with masks, quite supervised, and they're together after school, often without masks and without supervision. So we're still not believing the schools to be the center of spread, although of course we're seeing those cases. So hope that helps.
Thank you, Dr. Scrace. And I think we have time for Jared Ebenreck again from KUNM. Go ahead, Jared.
Oh, hopefully you can hear me.
Yes.
Thank you. Jared Ebenreck, KUNM. I will go back to the questions I submitted about contact tracing. I'm curious then, given what you've said, how much more money is being allocated to that? What's the staff looks like? When is that all being downsized, or is it being repurposed for other purposes like outbreaks versus overall contact tracing? What is the plan, given that I'm sure budgets are being made, and the contact tracing thing was part of the ERD response? So I'm curious what's happening with that. Where's the money, and what's happening with the staffing? Thank you.
Okay, great questions that I happen to have answers to, thanks to my crack epi team and your conscientiousness of sending the question in advance. So one thing I will say though, before I give you the answer is, we actually do contact tracing in epidemiology, and I've done it, I think probably since John Snow first discovered that the Broad Street pump in England was the source of typhus. So this idea of tracking people down and finding out who they had contact with or where they got things, we've always done that, and we do it for other communicable diseases as well. So number one, no matter what happens with COVID contact tracing, we're going to need a core of people to do contact tracing for everything else. So I just wanted to get that out there, because as I've said earlier, my vision of contact tracing as we're learning to live with COVID is more about what your phone and the interconnectivity of internet and technology can do. Right now, we have 110 staff that work for DOH, an additional 50 staff approximately that are provided to us by the CDC Foundation, 160 total counting supervisors that work in that unit. Many other states like us are transitioning to automate as much as we can of that system, and so that you can be contacted, about your case result if you're positive, and there's even automation to contact your contacts as well, links to provide guidance. And so we'll still continue to investigate some cases. I think Jared, that people aren't as happy to talk to us on the phone as they used to be, often don't want to take the time. We try to be super nice. I don't think it's our fault necessarily, but people are tired of COVID, and I think some people feel like in some way we're telemarketers rather than people trying to stop the spread of a potentially lethal disease. Since 2020, we've used $17.5 million to support the contact tracing investigations and contact tracing unit. That's federal money that comes from a giant grant that we got to do this. And the monthly budget changes from month to month. And I think anyone who's ever run anything of any size knows that there's no possibility of successfully staffing a contact tracing unit to deal with 100 cases a day and 7,000 cases a day. So that's part of the challenge. And when it's a roller coaster, it makes it even more difficult. So we're hoping to provide automation as the main effort, and then reaching out in specific situations, and particularly for people without technology. And then lastly, we're working on solutions for NM Notify to expand that, and also both using that to report your case, and also a DOH portal where you can report if you're positive with home testing as well. And so, but right now on NM Notify, 42% of those who have smartphones have signed up. So that's great. It was 38% a couple of weeks ago. And so thanks to all of you who've gotten the word out about that. And for those of you who aren't worried about your phone exchanging signals with other people, which I'm not, because other people's phones, and again, you don't know anything. It is, when you get notified, it just says you've had a exposure. There's no way to know who that is, when it was, where it was. So it's highly anonymous. But I think you're going to see a remnant of contact tracing at its heyday, at its peak, back in late 2020, 2021, devoted to other diseases. Another group who continue to manage COVID for people who don't have technology, and then automation technology taking over. That's just my vision, but I think Christine Ross, Dr. Ross agrees with me, the contact tracing unit agrees with me that it's the direction we need to move.
Thank you so much, Dr. Grace. Thank you, everyone, for joining us today. We love feedback and again, work in progress. Thanks for rolling with us, and we hope you all have a great day. Take care.
One last word is hang in with us for another 2 to 4 weeks, okay? Like, remember that being on the downturn from like 6,000 cases a day to 5,000 cases a day, even though it's a downturn, it's still 5,000 cases a day. It's still more people than you've ever known to be infected with COVID, getting infected with COVID. It's still more New Mexicans. And so the downturn, when it happens, is, I hope, going to be sort of a, if you will, a harbinger of spring, 6 weeks later. And I'm really counting on that, at least getting a spring break in my job from these high case counts, kind of like we got last June from, that little mini summer vacation we had between the decline of the Alpha variant and the rise of Delta. So thanks for your attention, time. Be safe. No, be extra safe and stick with us for another 6 weeks. Thank you.